Hi, everybody.
Hi.
Good morning.
Good morning.
Oh, that's like more energy lah. Good morning. Thank you. Oh, almost full of the seats. That's very, very good response. Thank you for taking time off on a weekend to come and support the program. But this is your program, actually. Okay. My name is Helen Wong. I'm also a survivor. 9th year. This is my 9th year. And
I'm Peter. I'm an overcomer. She's a warrior. A big thank you to all of you who have come here, and also to the speakers, and especially the attendees, people like you who have taken time off to come this morning.
Dr. Sathish will introduce the program to you all. Okay, can I invite Dr. Sathish? Oh, you're using this one.
Good morning, everybody, and thank you for coming to this morning's session, which is the 2017 Annual Myeloma Forum. And I think this has been running for about 7 years, and this is my 5th year. I started in 2012, I believe, and I joined SGH in 2011. So in the last 5 years, a few things have happened. First of all, I think that we've had an increasing interest in participation from yourself, and I think it's probably because of a couple of things. First of all, there is increased awareness of this meeting that is going on, and secondly, I think there is increased demand from yourself to be participating in treatment, and the only way to do that is to be understanding of what's going on in the field of myeloma. So I think that's a very good and encouraging sign, and I think in time to come, I think that probably is only going to get higher and higher, the participation. And the other thing is that by doing this, there has been better sort of connection between us and you, and also with NUH. So now we have common studies going on, and ways of sharing what we do. So we have a standard treatment across hospitals for most patients. So we have kind of decided to standardize what we do, etc. So these are all things which are meant to increase the standard of care, or you don't get contrasting opinion from two places. And this is also in the process, increased our cooperation between the hospitals. For us in myeloma, it's an exciting year. It was an exciting last 5 years, in fact, and it's getting better and better. We have a number of new drugs already, and 2015 was a bumper year, which I'll show later. But in the next 2-3 years, we should be having even more coming out. So, and I'll show you later on how it has affected our quality of life and how myeloma patients have done in Singapore and worldwide. So overall, it's generally good news, and I think that unlike some of the other malignancies, some of the other cancers that we have in solid tumor, lung cancer, etc., pancreatic cancer, or even some kinds of blood cancer, multiple myeloma story has changed very much in a way such that patients now live with multiple myeloma. So earlier on, the focus was how to bring on a response. That was 10-15 years ago. Most patients wouldn't be alive for 2-3 years because there was no good treatment. Now it's a different story. Now we are looking at a situation where we need to make sure that patients have a good quality of life because they live for many, many years after diagnosis of multiple myeloma. So the focus has changed, and so is more demanding, because now we need to look at individual patient and look at what works well for that particular person. So it's exciting and at the same time challenging, and I think that we have a lot more work to do. So I'm hoping that from today's discussion, we have a packed, as usual, agenda for today. So in the morning itself, I'll be going on talking a little bit about what was revealed in the last meeting in America. We every year have an annual hematology meeting. I've tried to keep it very simple. And after that, we'll have Dr. Chung Wee-Ju talking a little bit about what we are doing in Singapore to improve the situation and get more studies coming out such that we have a better profile in the world. And thirdly, we have, neuropathy is a major problem with all multiple myeloma patients, and most of the drugs, unfortunately, cause nerve damage. So there are no good treatments, unfortunately. So the only way to deal with it would be, early recognition, And we find that, acupuncture is a very good way of dealing with it. And actually, one of our clinicians actually did a clinical study in combination with Bao Chong Tong about a few years ago. So now we refer patients who are eligible for acupuncture. So we have Dr. Tan Kok Sian from NTU. Thank you for coming. It's our way of incorporating modern science with what we think is really useful from traditional medicine. So I think that would be the wrap up for the start. Yeah. So I've shown this before, and I don't know whether there are some new people here. So I thought I'll show this again, and just to show how multiple myeloma drugs have evolved over many years. And as you can see, up until 1999, we didn't have a lot of drugs going on in this area. And the earliest drugs that came out was 1962. That was, about 50, 60 years ago. And after that came, the major thing that came around was use of autologous transplant. And that came in 1984. And you can see that it stood the test of time, because even now we have studies that are being challenging whether transplant is relevant. And we know that, it still has stood the test of time. It's still a good treatment for, transplant in myeloma. And then the major breakthrough started in the early 2000s when we had thalidomide coming. And then after that, we had Velcade coming. Bortezomib is Velcade. And then in 2006, we had lenalidomide. And most recently, carfilzomib, pomalidomide. And in 2015, we had some exciting developments. So daratumumab, which is an antibody, and elotuzumab, which is also an antibody, got approved in 2015. And also two other drugs, ixazomib, which is an oral drug, the first oral Velcade, you can call it oral Velcade, pill form of Velcade, got approved in 2015. And another drug called panabinostat has been around for a while, but it's a challenging drug to use. Anyway, even that drug is approved. So we have now a number of new drugs that are approved. And between this and here, there has been a change, a big change in how patients have benefited. And as I said, previously the lifespan would have been 2-3 years. Now, majority of about 50% of patients are alive, 6 years, 7 years, even longer. Not everybody is saying multiple myeloma is a very contrasting disease, with some people doing very well, some people not doing very well. So it's unfortunately not possible to look at who's going to do well, who's not going to do well in the beginning very clearly. We have some useful tests such as the chromosome study, bone marrow chromosome study, which can tell us a little bit, but it doesn't give you the whole picture. So unfortunately, right now, if you look at a situation where money is not a problem, if you go to USA where all the drugs are reimbursed by insurance and there isn't much of out-of-pocket payment, most patients would be advised to get the drugs in this end of the spectrum right in the beginning, such that cost is not taken, looked at or considered. The story is not straightforward here in Singapore because we are a payer, mostly paid by patients. So we've been careful in choosing, and moreover, we don't have any data to say that using these good medicines in the beginning, what happens if they come back later? What if myeloma comes back later? What drug can we use? So it's although we have a lot of drugs, it has also made us a bit more confusing as to where we go in terms of using these medicines. So I just thought I'll let you know when we talk about medicines, right? These words have been italicized and in red. And when we talk about drugs in myeloma, there are two classes of drugs. One is called immunomodulatory drug, or IMID. That's what is written here, IMID. So they all end up with mid in the end. Okay, so thalidomide, lenalidomide, pomalidomide. So these are all drugs that act by modulating immunity in your body. They also have some effect in the cancer cells, but we call them by a pet name called IMID. So we have a first generation IMID, which is the oldest drug called thalidomide, then second generation, which is lenalidomide, and then the third generation is pomalidomide. So they're all IMIDs. The second group is what we call PI. PI is proteasome inhibitor. So when the doctors talk about PI, Velcade is one type of proteasome inhibitor. You have another one which is called carfilzomib, which is the second generation. And then there is a third one, which is ixazomib, which is the pill form of Velcade, which is the first pill form of Velcade in the market. And finally, we have this thing called MAB, which is basically called monoclonal antibody. So that is a easier way of understanding what kind of drug it is. If somebody tells you that I'm on daratumumab, the last word mab means that they're on an antibody against a particular disease. So there are two types that we have right now, daratumumab and elotuzumab. Okay, so these are all because you have to deal with this often and often. It's good to know these names a little bit. So I'll start with what we do in Singapore, and most of you have gone through this, but I think I just thought maybe for the people who are here in the beginning, we use generally 3 medicines in the beginning for starting treatment, and we always use Velcade as a backbone. So in myeloma, the other word is backbone. What is a backbone? Backbone is a drug that cannot be changed and has to be there in the combination. Okay, so if you go to USA, for example, they'll have 2 new drugs in the backbone. They'll have an IMiD as well as Velcade in the backbone. So they have, because cost is not an issue, they might use double novel agent backbone. In Singapore, we tend to use mostly Velcade, cyclophosphamide, which is one novel agent, Velcade. Cyclophosphamide is a chemotherapy, and dexamethasone is a steroid. Or in some patients, we use just a combination of novel agent only with one drug, so it's a doublet. It depends on the patient. Generally, older patients above 75, more side effect toxicity problem, we might use just 2-agent drugs. In some patients, we use other kinds of pill chemotherapy. So generally, it's an injection with 2 kinds of, either a steroid plus another kind of chemotherapy given as pills. That's what we normally do. And there are some medicines that we normally give for supportive care, which is to reduce infection and other complications that happen with myeloma. So here, if you are transplant eligible, and when I say BMT, that is transplant. BMT eligibility is not decided by really your age anymore. So we have patients who are 70 who are fit, 71 who are fit patients. So age used to be the cutoff previously, but we don't use that cutoff anymore. We look at tests like your heart function, lung function, kidney function. Are you able to walk 1 kilometer without getting breathless? Are you able to go up a flight of stairs? These are more important than just numbers. And if you think that you're eligible, we would always consider transplant, okay? And if you're not eligible because of your age or activity status or your other problems, then nothing changes except that we don't do transplant in such patients. And after treatment, after transplant, what happens is still a gray area, okay, at least in Singapore. Some patients we will decide to stop treatment, and whereas some patients we will discuss maintenance. And it's not fully clear as to whether everybody should get maintenance. So this study called Stamina Study was published in last December. I know somebody who here actually went online and looked up the study and told me the name before I told them. So this study, there's a lot of words in there, but I'll make it simple for you. PFS stands for progression-free survival. Again, doctors, when they talk to you, right, this word will come out all the time. And OS is overall survival. They are slightly different. Progression-free survival means living without myeloma getting worse. Whereas overall survival means living, and that might include your myeloma getting worse and getting a new treatment. So they are slightly different. So PFS tells you that, how effective was the previous treatment, whereas overall survival might also mean the effect of another drug that has been given to you later on because your myeloma came back. So this is always coming into our discussion all the time. And because you're going to deal with this problem for a long time, when doctors talk to you, just to make it clear, PFS is what we normally use to look at an effectiveness of a drug. But increasingly, we like to see an overall survival benefit as well, which means that we need to see a particular drug causing the person to live longer. We just don't want them to live longer with the progression. Okay, we want them to live longer without progression overall. We want to see that benefit, as in their lifespan, rather than just the progression-free survival. It's a challenging problem because we have a lot of new good drugs, and it's very challenging to show superiority because these drugs can be put in at any time, and it can compensate for the effect of a particular drug. So this study looked at 2 questions. First of all, is there use for second transplant in all patients? The second question was, is there any benefit of consolidation, which is a short course of chemotherapy after transplant? Or, is there a role for so these are the two questions they asked. Is there a second transplant beneficial or a consolidation beneficial? We don't do either here on a routine basis. So in Singapore, what we normally do is to have a single transplant, and then we might even stop treatment. We don't get maintenance for majority of our patients. But in this study, everybody got maintenance till the disease came back. And they used lenalidomide for maintenance. Everybody got melphalan, which is transplant, and then they had this, two options of giving a second transplant and then maintenance, or instead of second transplant, going for consolidation and maintenance. And so if you look at the outcome, again, PFS and OS, okay, so progression-free survival, overall survival, you can see that at about 36 months, they all look very similar. Okay, so a second transplant did not help in majority of patients, okay? And consolidation also. So the three different arms are, this arm got single transplant, this arm got consolidation, the other one got second transplant. So you can see that they all are hugging each other. So it shows that, in a large-scale study, we had about 700 patients in the study, no difference at all in outcome. So it questions whether everybody needs a second transplant. Probably the answer is no. And the second question, do we need to consolidate with more chemotherapy after transplant? Maybe the answer is no. But this, you have to understand that this is a big study, and it has people who may have benefited from the study, from a transplant, but because we are looking at everybody together, we can't come to a conclusion like that. So everybody is different. A study, a big study gives you big messages, but it may not apply to individual patient. So when we discuss, every single patient is different. But it at least tells you that on a large scale, doing extra transplant or giving more chemo after transplant doesn't seem to help. So the message for me, at least in Singapore, is that everybody who's in a transplant age should be offered a transplant, one transplant, not a second transplant. I'm talking one transplant. One transplant, if possible, should be offered, because you can see that it's, the line is really not different to people who had a second transplant. So when we talk about transplant, if possible, we should always offer a transplant to patient. The second question is perennial, has been forever. And if you go to US, Europe, Asia, the story is entirely different. I just thought I will show you some data which seems like is becoming a message, because the same thing has been shown in multiple studies. Okay? And so this study looked at least 3 big studies who have used lenalidomide maintenance, not thalidomide, lenalidomide maintenance after transplant or in patients without transplant till it came back. In one study, it was used up to 2 years. The other one, it was used for a longer period. And it looked at whether it really caused people to live longer. So you can see that the numbers are quite high. You can see that about 700, 800 patients are there in that study altogether. And if you look at the overall survival, okay, so when they looked at control are patients who do not get maintenance, and the blue line are the group of patients who get maintenance. So we know that previously we knew that if you use lenalidomide for maintenance, progression-free survival is certainly there, which means that these people have myeloma coming back, which is clearly delayed compared to patients who do not get maintenance. So that is very clear. But what we didn't know was whether maintenance would cause you to live longer, overall survival, because that is more important for most patients. And this is the first analysis that really showed that using maintenance does prolong your life, okay? And not just progression-free survival, but even overall survival. So the main message from them is that if you use maintenance, you have to use it for at least forever. So that's what the message is, because the benefit seems to be coming from prolonged usage of a drug rather than a definite period of usage. And I have a problem with that, and I think some of the other people also will have a problem with that. They found that on an average they live 2.5 years longer compared to people who did not take maintenance. This study had only 10% of patients who had very high-risk myeloma. 90% had non-high-risk myeloma. So we can't make a conclusion of people with high-risk myeloma from this study. When I say high risk, this is chromosome changes which are not very good, et cetera, et cetera. So there are certain things that we call myeloma as high risk. There is also increased cancer in people who get maintenance. There's about 3-4-fold increased risk of getting secondary cancer from maintenance. But even with that, more people in the treatment arm survived because they died less from myeloma. So is that clear? So people had more life, even if you look at big numbers. Some people died of cancer, but overall, if you look at 100 people who got maintenance and 100 people who did not get maintenance, more people were alive in the treatment arm because they lived longer without myeloma. So coming to our context in Singapore, there are a few things that are very important. You're talking of a drug that is not cheap, and you need to take it for possibly indefinitely, okay? And this has two issues. First of all, who's going to pay for it? Medishield Life covers up to $3,500 per month, but this medicine costs about $5,000 per month. So, over years, this is going to add up. That's the first thing. Secondly, side effects of this medicine are not insignificant. Everybody gets side effects to varying degrees. So, these are two issues that I always discuss with my patients. And thirdly, I don't even know whether, what would have happened if we didn't treat them, but if they had myeloma coming back, we treat them, whether it would have made a difference. So, we don't have any study which is comparing people who got treatment versus who did not get maintenance when they had myeloma coming back. So for all these reasons, my stand on maintenance is that I will not offer it to everybody. I would probably observe patients first and see how it is. There are some cases where I would think of giving maintenance very early on, where people have not had a good response to treatment, where we know that the myeloma has come down, but only say 50%, 60%. If it has gone down very low after transplant, my inclination would be to stop treatment and observe because of all these reasons. This is something that is evolving, and over time we will know more. But I think that it's something that you probably have to understand that in studies it's been shown that people live longer, but it may not apply for everybody. Some people may not even need to spend that money or compromise on the quality of life. So the next thing is biological therapy. Okay, so the next major thing. So this is about the antibody that I talked about earlier, and I have a video here because I think probably it will help us show. This video shows, I don't know whether you got a chance to understand it, but it tells you that there are various other ways of. So far, we've been only targeting using some medicines, which we believe will kill cancer cells, but we have not really used that much our own immune system to target cancer cells. So the good thing is that we have a fabulous immunity, which does get affected when you get myeloma. So your immunity is not 100%, or even much less than that when you get myeloma, because plasma cells are the cells that you make that make antibodies, and they are precisely the cells that multiple myeloma affects. But despite that, there is body's ability that can be tapped. So one of the drug that, as mentioned there, is an antibody which can go and tag on to a particular antigen that is expressed by cancer cell, and thereby attracting our own killer cells to come and kill them. So this treatment has been around in lymphoma for about 10 years, and it has changed the way people live now. People live on an average, years more than when they didn't have the immunotherapy. So the first in-class immunotherapy that came out in myeloma was this medicine called daratumumab, called Darzalex. And it works in the same way, so I don't need to spend time on that slide. So what they did was to look at this big study where they compared patients with the myeloma which has come back after one line of treatment, but who are not refractory, which means that the Velcade was still working for them, to two groups. One got Velcade and dexamethasone, and the other one got daratumumab with Velcade and dexamethasone. So the one arm got extra medicine. And big number of patients, they had around 500 patients in the study. And this just shows you the number of the differences between the two groups. So the two groups were very similar in terms of what number of treatment they got, what drugs they got before, etc., etc. So it's a balanced population group. And if you look at the progression-free survival, not overall survival, progression-free survival, you can see that the median progression-free survival for people who got Dara, Velcade, Dex was significantly higher than patients who did not get Velcade, daratumumab. So it's one of the drugs that potentially can, has been shown as a way of changing, just like Velcade, when it came around in 10 years ago, Velcade changed the way we treat myeloma. People live a lot longer thanks to Velcade. Now we have daratumumab, which is the next, I would think, the next sort of drug that we have immediately accessible, which can change the story again. There are a lot more in clinical trial called elotuzumab. There is another one, a couple of other drugs. So I think in 5 years' time, we'll have at least 2 or 3 more drugs which we can use just like daratumumab. So the only problem with these medicines is that they are antibodies and they can cause infusion reaction, allergic reaction. So I've seen that in my own patients. So always the first 1 month of infusion, or at least 2-3 weeks of infusion, I would advise them to have it as inpatient so that we can observe them closely and give the anti-allergy medicine, etc. Because what we don't want is that they get an allergy very bad, that they get scared of this medicine and forever and not take them. So it's a good drug. We don't want to miss the opportunity. So so there are things that we need to learn about this medicine. And we've started using it, but some of those patients that I've seen, when they get scared with the first very bad allergic reaction, that can scare them away for life. So we don't want that. The other thing is that this can affect the blood group of the patient. So if you need blood transfusion after getting this medicine, the blood grouping system is a bit messed up. So we need to do all the necessary tests to make sure what exact blood group you are before we start giving you even the first dose of this medicine. So these are things that we've not done before in myeloma. So there are things that we are learning. But I think in time to come, we will learn a lot more and we'll have a lot more patients using it. But the biggest problem is, of course, the cost and access. So we have it approved in Singapore about a month ago, 2 months ago. So we can get it now in Singapore, as opposed to last year when it needed to be imported from US. Cost is a problem. So we are working with the companies in terms of reducing the cost and making it more affordable. So I just want to show you a couple of slides of how things have improved for us in Singapore. So this is just a trend of how people lived in different generations. So the lowest one is from 1998 to 2001. The most upper one is from 2008, from 2012 onwards. So it's looking at a large number of patients, and you can see that previously the curve was going right down. But in the most recent era, every single 3-4 years, we've seen that improvement coming on. Okay, so we now know that people live longer. This may not be as good as we want to see. We want to see everybody living right like this, a flat line, where everybody is alive 5-10 years from now. But unfortunately, that's not the case, because still we have significant number of patients who fail treatment and myeloma comes back. And if you look at a comparison between before using Velcade and after using Velcade, you can see that, again, it has resulted in improvement. Small improvement, and it's probably not worth boasting about. But I think that, we are trying things to, whatever we are doing is working to a small extent. And it's a good reassurance to say that we should keep doing the same. And if you look at people who are older, 71 to 80, the median age is 65. So if you look at the older population, so it's not just the young patients who go for transplant that this has helped. If you look at the older population, also we can see that even in the age 71 to 80, you can see that people are living longer now. So overall, we can see that regardless of your age, whatever we are doing has certainly improved the way now people survive. And we can see that in the clinic, because most of our patients have now lived with myeloma for years. And I have my own patient who's sitting right there at the back who will tell you about his own story about myeloma, living with more than 10 years of myeloma. So with this, there are a few drugs that are available. Most of the drugs that are approved we have in Singapore, including, ixazomib, panabinostat, carfilzomib, pomalidomide, daratumumab. The only last one that is not available is elotuzumab. So I think that final thoughts have remained the same. Not everybody can be considered the same. Everybody's different in their disease and their physical and their social and other problems. So we need to look at treatment in the context of the whole body and their family and other things. We have a lot of new medicines, and I think that we need to figure out which medicine to be used at the beginning, et cetera, et cetera. That's more challenging, because we don't want to be going there and getting all the good drugs in the beginning and using them, because what would happen if it comes back? Okay, so we've been rational in using medicine in such a way that we have a lot of options later on. Yet we know that the best quality of life from myeloma always comes from the first 10 years of disease. Okay, so we want to maximize it, not compromise it. Both financially and for your quality of life. So we don't want to burden with a lot of medicines such that you become paralytic or cannot walk because of very bad nerve problem, etc. And yet we also want to give them the best option of living long with myeloma. So they are completely opposite philosophy. On one hand, we want to make their life easier. On the other hand, we want to do the best for their myeloma. So it's totally different things, and it's very hard to juggle. But I believe that what we're doing is right. We are not doing the best probably, but I think there is room for improvement. But hopefully in the years to come, I think we'll have better understanding and people will live a lot longer. So that's my final slide, and with that, I thank you.